Today we have Dr. Posadas, someone who is making quite a name for himself at Cedars-Sinai. We lost him on the East Coast, but he trained in Michigan and the NIH, and then made his way over to Cedars-Sinai for now. So we're going to talk about the AUA Salvage Prostatectomy guidelines. Tell us who we're talking about.
Yeah, so the field of urologic oncology is so multidisciplinary now. I kind of grew up with it, but it's nice to see this happen. And one place that this really matters for patients who've had prostatectomy that have had their PSA come back, because this is a moment of terror for men who had thought they were done with this business, and now they're trying to figure out what to do next. And are they still curable? What does life look like for them in that immediate period? And then are they going to be around 5-10 years afterwards? So optimizing their care is really, really important.
Absolutely.
So our educational session was based upon guidelines that we just put out between the AUA, with a lot of input from radiation oncology and medical oncology on how to optimize the treatment of men with postoperative PSA recurrence that are undergoing salvage radiation, in terms of how to do the radiation, and even what to do with all the systemic therapy that comes along with it, when to do it, when not to do it. And so hopefully we put some information out there that brings the field up to date, since the guideline hasn't been updated in more than a decade.
Right. And so these guys, these patients, we don't have so much great data for them, but what do we know about these patients?
Yeah, almost unfortunately, 30% of men, even with the improvements in surgical technique, they still relapse after they've had their prostates taken out. Now, what we're finding is, in more contemporary practice versus where we were a decade ago, we're catching them earlier. We now have the addition of PSMA PET in our armamentarium, even fluciclovine before then, but PSMA PET has really kind of changed the field. And it really has us rethinking how we approach these patients. Plus, with the improvements in our understanding of the biology of prostate cancer, there are more and more questions about, how do we incorporate this into our practice? Does this mean that we need to change our systemic therapy approach in addition to the local approaches to these men? And so it creates a nice forum for multidisciplinary discussions that urology has really kind of spearheaded for a long time, and is really kind of moving forward.
Okay, and so these patients are patients PSMA negative?
So we have a little mixture of both. Okay. Historically, the field of biochemical relapse was built on patients who had biochemical recurrence with a CT and bone scan that were negative. But with the addition of PET, we're now finding that some of those patients actually do have a detectable pockets of early metastatic disease. It's a little bit of a nuance, though, because this is not quite the same as the patient who has a positive bone scan with a rising PSA, and they have macroscopic disease, or you can see bone lesion, enlarging lymph nodes on a CT scan. It's earlier, and hopefully that these earlier findings lead us to better care and to greater cure for these men that are seeking the cure from the time that they showed up at your office saying, "Please take my prostate out."
Right. And so what do the guidelines teach us?
So the guidelines look at a number of different factors. We really kind of emphasize that there are some high-risk features present in the postoperative setting that kind of make you think about treating patients more aggressively. These are, it's going to be no surprise to the urologists out there. It's your higher grade disease, your larger tumors, your T3s plus, seminal vesicle involvement, rapid PSA doubling times, persistence of PSA after prostatectomy, and in these patients, we really tell folks one of the big messages is, if the PSA comes back after surgery, even with a negative PET, don't delay. Don't put this off and say, well, we're going to wait until something shows up. I think that's one of the big mistakes. But for high-risk patients, they probably need a little something more than just SRT, because you want to get them to cure. I mean, that's really the penultimate goal. No one wants to be on long-term ADT. I'm a medical oncologist. I do this on a day-to-day basis, and men don't like hormonal therapy because it's
No,
not.
they do not.
It's not natural.
Right.
And so whenever there's an opportunity to avoid that, believe me, I have all guns firing with urology and radiation oncology to help men get across that line.
Okay, and so you're treating this before things become...
Before they become metastatic. Now, there are times that we'll see things on a PET scan, maybe an isolated bone lesion, some lymph nodes that may have been, and we were discussing this in the educational session, with the prostate present, it becomes kind of a big sink for all the PET tracer to come up. So maybe you've unmasked some nodes that are present. There may still be an opportunity to cure these guys. And one important thing about finding these, especially in the pelvic recurrences, is that rad-oncs can actually target those in addition to the bed.
Right.
And it really does improve outcome. It improves failure-free survival, metastasis-free survival, and we're hoping, as data matures, that it's going to result in better overall survival. But I think those are 2 points enough to say that it prevents men from needing to be on long-term ADT, and it prevents the disease from spreading. That I think men really want to have that option put in front of them to kind of talk about the pluses, minuses, and decide whether or not they want to incorporate that into their post-prostatectomy treatment.
Okay, so let's say you have a patient who underwent a prostatectomy. Mm-hmm. Everything was okay, other than seminal vesicle invasion. PSA after goes down to near zero, and then he has a very aggressive PSA doubling time. What are you doing? What are we talking to him about?
Yeah, if you catch him early enough, I think one of the nice things that we're finding is for PSAs that are around 0.1 or so, because you really want to get these guys to salvage early. Sometimes you can get away with salvage without using any hormonal therapy. And I think that's a really important option for men, again, because of the negative effects of the hormonal therapy. So, a PSA of 0.1, even with seminal vesicle involvement, and especially if there's a positive surgical margin, let's say, or it involved even microscopic surgical margin, those guys are really going to do well with SRT, and it will get them sealed for a good long-term benefit. And that's a difference maker. So those guys, we got to find them early. We got to initiate the multidisciplinary care that happens between urology and rad-onc and med-onc. We kind of hang out in the background saying we're ready if we need to jump in, but we'd rather not if we don't have to.
Right. Interesting. So, what are your three biggest takeaways?
I think the 3 biggest takeaways that we have from this session are for men that have PSA recurrence after prostatectomy. You don't want to drag your feet. They should be involved in multidisciplinary care. And it's wonderful that urology has for a long time now been driving, more than other fields of medicine, this kind of multidisciplinary interaction. I think the second thing is that consideration, especially for men with high-risk features or higher PSAs, of more advanced molecular imaging should be a consideration in order to refine the approach to their salvage in terms of the focal nature. And for the highest risk patients, a question should come up about whether or not to use hormonal therapy, and that discussion should be a shared decision-making process between patient and physician about what the ups and downs are and how to optimize it to meet a patient's goals in terms of quality of life and survival.
Excellent. And what should we expect to see going forward next 10 years?
Yeah, so the great thing is with all the advances being done with the clinical studies, some of which are completed and maturing and others that are coming online, I think we're going to see the incorporation of more molecular features into this triage, so that we'll be actually thinking about the biological program and its responsiveness to hormonal therapy. I think we'll also see, what I'm kind of excited about is that there'll be kind of the next generation of imaging agents that come forward. I think PSMA has been really important for us, but we thought CT scan and bone scan were the next best thing to sliced bread a few years back. So I think looking forward, but not forgetting the lessons of the past. So MRI, for example, looking looking at those pelvic recurrences, not just kind of focusing on PET, but thinking anatomically what's happening there, there's no substitute for that. So remember the past, look forward to the future, bring in the next generation of data coming in, and support the clinical studies that are going on, because they're difference makers, and the urologists have always been great about making sure that these studies happen and get to completion.
It's awesome. And going forward, I assume there's going to be many changes to these guidelines as we understand these patients more and more.
Yeah, I think there's still a lot of open questions, and one of the nice things about this session was that the folks that were present were really kind of putting in the real day-to-day questions that we have about, when do you get that? When exactly do you get the PSMA? What's the PSA doubling time that makes a difference? What's the role of local imaging to answer these things out? And we're getting that data as it's coming in. Does Decipher or Artera, do they make a difference in how you approach these things? I can tell you what I think, but there's opinion and then there's data.
Right.
And until we get that data, it's hard to change a guideline, especially one that is put forward by the AUA, which has a very, very strict approach to how we put these things out. So the urologists are always acting on the best level of evidence.
I think that these patients, I think every urologist struggles with these patients. Well, what do we do? When do we do it? Delayed, early? And so just having this is really great.
Absolutely, and the fact that we do this at the AUA meeting, I think it is really, really appropriate, because it really kind of exemplifies the kind of team care that's happening in urology now. So I'm happy to be a part of it.
Absolutely. Thank you so much for joining us.